everyone. And first of all, on behalf of Intas Pharmaceuticals and the Nexa division of Intas, I, Dr. Sandesh Vodkar, very warmly welcome you all to yet another episode of Lipid Lectures by Lipitas. The objective of Lipid Lecture series is to explore evolving cardiometabolic insights with the country's leading experts. And in these episodes, also, two distinguished speakers will address two critical dimensions of cardiovascular care. So in the first talk, Dr. Johan Christopher, he will be talking about the use of combination therapy early in ACS management with statin and ezetimibe combination upfront. And in the second talk, Dr. Rajesh Wag, he'll be talking about another critical aspect with regard to the women and lipids and addressing the critical gender by specific with regard to the gender differentiation. Uh, so first, it's my pleasure to introduce our first speaker, Dr. Joan Christopher. Dr. Christopher is the director of non-invasive cardiac imaging at Care Hospitals, Hyderabad, and head of the DNB cardiology program. He's trained internationally and fellowship in cardiac imaging from Brigham and Women's Hospital, Howard Medical School, USA. He holds MD in medicine and DNB in cardiology with extensive experience in advanced cardiac imaging and diagnostics. He has expertise including echocardiography, cardiac MRI, CT angiography, nuclear cardiology, and functional cardiac testing. He is also experienced in critical cardiac care, including ICCU management, invasive procedures, and hemodynamic monitoring. He is also active academic contributor with research publications in echocardiography and coronary imaging. So with this, I would hand over the session to Dr. Joan Christopher for his talk on the usage of combination therapy, statin plus ezetimibe, early in ACS management. Over to you, sir.
Yeah, thank you, Dr. Sandesh, for the kind introduction. Thank you, Intas, for this wonderful platform. I'm just going to share my slides. And a big thank you to all our physicians who have joined today, for taking time out from their busy schedule. And I'll just, so slides visible?
Yes.
Yeah. So today we're going to talk about something interesting, and this is the combination therapy of statin and ezetimibe upfront. And you all know that we are faced with an unprecedented challenge of atherosclerotic cardiovascular disease. One third of all deaths, 30 to 35% of deaths globally and in India. The deaths are by ACVD, lot of concentration in Asia, especially Southeast Asia and Central Europe. And we have a unique challenge of having patients having ACVD very early, and that's derailing the GDP because we have a lot of young people in the ICU and not in their workplace. What we have seen is, although there's a plethora of modifiable risk factors, what is very, very clear is that it's the LDL which is the driver for ACVD. And if you look at the causal ratio for ACVD, when you look at diabetes, smoking, they're all in the 3 to 3.54, and dyslipidemia and high LDL is 8, which means it's head over heels above all modifiable risk factors. Now, as you know, it's not only the death that we're looking at, it's about the loss of days at work, which is really driving this problem, and that is allowing governments and the private sector to really look into this problem and make corrections and look at how we can change this natural history of this very, very nasty disease. Now, if you look at the global drivers of change, you will see that metabolic risks are right up there, followed by behavioral risk, and then occupational issues like pollution, which are also increasing as we speak. And unfortunately, most of these problem is happening in the global south, so to speak, which is the developing and the newly developing countries, and that's causing a huge problem because these countries are already under a lot of debt crisis. They have a lot of mouths to feed, and when you have this kind of a non-communicable disease problem, then it becomes a very, very important economic problem. And it is in this kind of milieu of an economic issue facing governments across the global south that people have started looking into how we can get modify the risk of ACVD. And now that we know that the focus is on LDL, how do we get the LDL down in a very safe, effective, and replicable manner? Now, in the entire ACVD, the one which is very, very crucial is the ACS period, because ACS is the time when the chance of death is the highest at admission at the first week and also the first 3 months post discharge. Whereas the chronic CAD will have symptoms, but the deaths are actually quite low. So that is the reason our whole strategy when we look at patients with coronary artery disease is, does he have ACS and what's my strategy? Is it a chronic stable CAD, someone who didn't have problem, had an abnormal treadmill nuclear scan, and then had to have a procedure? So the whole management is based on whether he had an ACS versus a chronic stable angina. Simply because, as I said, these patients have a very, very high event rate, almost as much as 33%. We already also understand now that the plaque is the center of our imagination in terms of the risk during ACS, and a hot plaque is very, very important for events down the line. As I said, the first week and the first 3 months, and the mortality also seems to be related to the plaque and not the degree of stenosis, which is more in chronic CAD, which causes angina, limitation in movement, but really never death. So when we have a hot plaque, lot of efforts go into how to ameliorate this hot plaque. And since the plaque has a lot of LDL, a very rapid reduction of LDL, not only coming down to goal, but coming down rapidly down to goal, because as I said, the first week and the first 3 months, the mortality is extremely high. So it's just not good enough anymore to get the LDL down, but to get it down very, very quickly so that the vulnerable period, the period where the LDL is still above the requisite level, is as minimal as possible. Now, we have been dabbling in potent statins. There was a time when I used to use high dose statin, defined as 40 rosuvastatin and 80 atorvastatin, and we would never ever bother to check the LDL. And we were so happy and proud that we were able to use these high doses. But unfortunately, the data reveals otherwise and showed a massive gap between what we were doing and what was actually the expectation. And the Da Vinci study, which was a very large observational study in Central Europe, clearly showed that using high dose statin, only less than 20% of the highest risk people achieve the target of less than 55. And this is Central Western Europe. And I can't even imagine how many percentage of Indians would really reach the goal. And I'm just putting that number to maybe 3 to 4% or 5%, nothing more. The Santorini study again confirmed that 30% of Europeans only reached the goal. And again, the goal registry in the US again showed only 1/3 really reaching the goal, which means high dose statin alone is just not good enough. And we have a lot of residual risk for most of our patients moving forward. Now we know the mechanistic action of statin on the HMG-CoA reductase, reducing hepatic cholesterol, and thereby upregulating the LDL receptors on the surface to get some more cholesterol, and thereby the LDL receptors attract the cholesterol, which is the LDL, and therefore decrease the LDL. Now the estimate is, on the other hand, has a very complementary pathway at the intestine using the NPC1L1 protein in the small intestine, and that decreases the absorption of cholesterol and uh, gets the cholesterol out through the intestine. And this synergistic dual pathway, both targeting the internal synthesis as well as the external absorption, seems to be much more efficacious than just doubling the statin dose. And what we know for certain is when you double the statin dose, you get a 6% additional LDL reduction, while you add estimab to a statin, because of the very nice complementary and synergistic pathway, you get a 24% reduction. We also know that statins are essential. Statins are the bedrock. Statins are the fundamental um, pillar. It is the foundation of ACS therapy, simply because they don't reduce cholesterol alone, but they have a slew of pleiotropic vascular benefits, including but not completely plaque stability, decreasing cytokine, decreasing macrophage, decreasing the lipid core, increasing the fibrous cap thickness, rather cementing the plaque. And therefore, you would see the calcium scores actually go up. The coronary calcium scores actually go up in patients who are on statin, which does not mean that the risk of CAD is more. It just means that all the lipid-rich plaques are cemented, are calcified by statin, and therefore the calcium score goes up. Now, what happens when you give estimate is there is a further acceleration of this process of decreasing the lipid core and also increasing the fibrous cap. And here you will see the classic left side where you have the lumen, which is reduced, and you have the plaque, and here the yellow area is the large lipid core. And this is what we would call a vulnerable plaque because of two reasons: the large lipid core and the very thin fibrous cap. And this, on the other hand, is a plaque which has been treated with statin as well as estimide. And here you can see the lumen remains the same. The statin does not cause improvement in the lumen, but what has happened is at the plaque level, the lipid core has shrunk and the fibrous core has increased, and the thin cap fibrous cap is no longer thin, but it is nice and thick and maybe even calcified. Now, how are we going to know what is happening? Now we have data from the intracoronary data. We have data from the coronary CT, which is more external, non-invasive. And we have functional studies like the NIRS, or near infrared spectroscopy, which is now mounted on an IVIS machine, which can identify these lipid-rich plaques. We now have a lipid core burden index, LCBI, and the number we have right now is more than 400, where if it is crossing 400, there's an independent predictor for future MACE. The Pacman study again showed that if you can add adalimumab to the high intensity statin, you get a much more plaque regression and lipid reduction. The Huygens study showed that using evolocumab again in these patients with OCT again is decreasing the lipid core, increasing the fibrous thickness. So we had the hypothesis that these drugs would decrease the lipid core, increase thickness, and the imaging studies, both the coronary CT and the invasive studies using both IVIS, using NIRS, and the OCT, clearly showing that these plaques exist and they are modifiable if you can get the LDL down using a combination of statin, estimide, and allosimab. Now, with all the data that has been coming, finally the guidelines sort of woke up in 2023, and over the next 2 years, the European, American College, and the AHA, and finally the LAI. Surprisingly, the LAI has given the highest recommendation and the almost, I would say, the lowest LDL goal of less than 50 milligram based on the Indian data and the Indian phenotype. that needs to be achieved within the first 4 weeks, because I told you the first month is very, very crucial in terms of events. So if you have a patient with ACS, it's not good enough to come down to 100. It's not good enough to come down to 75, but you need to touch 50. If you look at the LI guidelines, it's if the American college is less than 70 and the European is less than 55. So the Indian ones are the actually the most demanding and challenging of the guidelines, and very aggressive guideline recommendation. So anything less than 70, I would say, if you look at all the guidelines, is the way to go if you are post ACS. And how are you going to do it? You need to be on the bedrock foundation stone of statin, and over that, um, you need to add estomide, and if it doesn't, then bempedoic acid, and finally you can use evinacumab. Any of the PCSK9 inhibitors can be used. So we have moved from high intensity statin to a high intensity lipid lowering treatment. As I said 10 years ago, I was very comfortable with high dose statin. We never really looked at a goal. We never looked at the lipid, both at the time of admission nor at 4 weeks. But today we have a very important message to the ER staff that any patient that comes, even in the night with an ACS, we want a lipid profile at the time of entry. We don't want to wait for the next day morning where it could be missed. We are now very comfortable ordering non-fasting lipids, and except for the triglycerides, the LDL generally maintains its level even in the non-fasting state. So entry level of an MI, we get a lipid done and we repeat the LDL at 4 weeks time when they come for the big follow-up, and we want to make sure we have come down by at least 50% and we are reaching the less than 70 goal. The Indian landscape, as I said, is very important because we're getting these patients very early. Our LDL targets are really nowhere near what the Europeans are able to do. And we also realize that for us, we cannot go down to 70 because our risk is much more. We really need to go down to 50, and that is what the LAI guidelines have really put forward. Now, subsequently after the guideline came, the OLA study looked at rosuvastatin estomab combination right at the start at the time of ACS admission, and they showed that there is a 45% reduction in the LDL. LDL moved from 115 to 43 right across all the subgroups, and what they really showed was that just using oral therapy, that is high dose statin as well as the estomab, can achieve the goal compared to just statin alone. And this was interesting because 75% of the patients are achieving the goal compared to only 30% of the patients with only rosuvastatin. And surprisingly, by the 6th week, almost 93% would reach the less than 70 goal, which is American College guideline, and 70% are reaching the LAI guideline. And all this is happening by the end of the second week, and definitely by the first month, which is also the time where the maximum events are taking place. And they continue to be low. They continue to reach the guidelines over the next 4 to 6 weeks. So first 14 days and the first 1 month is a very important time because of the increased level of events that happen. And that's the time when you have the combination really working well and getting 75 to 90% patients down to goal. Now the LI early ACS study used atorvastatin with estomib 10 compared to only atorvastatin, and all these were given right at the beginning of the admission, and the LDL reduction even by week 1 was almost 15%, 50% more than the people who were not on the combination. And by 4 weeks, half of the patients reached the goal compared to only 30% who were only on atorvastatin 80 milligrams. And at 12 weeks, 60% reached this goal compared to only 40%. So this really changed the landscape wherein early administration of statin, Atrova 80, with estimate 10 right at the entry. We call it the emergency dual therapy. For the first time has shown excellent results at week 1, at week 4, and also at 12 weeks in terms of reaching the live, very aggressive goals. So 50% reach the goal in the combo group by 4 weeks, which is a good thing. I've already told you the importance of the first 4 weeks, and by the first 3 months, which is again a very important time for events, 97% or most of your patients reach the less than 70 goal, and that's very important because the events really started coming down. And by 12 weeks, uh, about 50 to 60% of the patients would reach the aggressive goal of 55, and another about 60 patients would reach the aggressive goal of less than 50, the live goal. Now, what is also important is that the HSCRP levels are also coming down in both groups, confirming the very strong anti-inflammatory benefit of the statin. Now, the big advantage is not only getting down to goal, but also at the end of 2 months, the two lines start diverging in terms of event rates, especially mortality, and the lines continue to divide over the next 3 years, and the numbers needed to treat to prevent one death was just 21, which means that if you start your patient on a dual therapy, you're going to have a much higher survival, almost 48% more than someone who had to only be on statin. And from the 14th day onwards, you would start seeing these lines separate. And by the first 3 years, you would find that the lines are significantly separated, which means your patients on dual therapy are going to live long. So all the modified risk factors are important. That's very important. Rosuvastatin slightly better than atorvastatin, and rosuvastatin with estimate is much better in terms of LDL goal, as well as it has a survival benefit. And real world lipid management, again clearly showing you that most patients are not on dual therapy. Only 2% were on dual therapy, and almost 90 plus patients were on single therapy, which means that if you have to reach the goal of a 20% um, reduction in mortality, you need to be on dual anti-lipid therapy. Now, the Sweetheart registry in Sweden, again, um, is a very, very important registry covering more than 90% of patients. And there also, in almost 35,000 patients, 17% received estimate early, whereas the majority, 65%, did not receive the drug at all. Very large number, 98% of patients were on high intensity statin, and yet they were not reaching goals. And the people who were on the estimate combination were able to reach the goal better. The 1 year MACE was much better. As you can see in green, the MACE was really low compared to no estimate, and those who were started on estimate late got an intermediate kind of benefit. So almost an 83% increased risk of death at the 3rd year if you were not on estimate, and 50% of the patients would reach the LDL goals if you were on estimate early. And this is just to show you that you're reaching the goal early and your mortality is very, very low compared to either late estimate or no estimate at all. So if you don't give estimate, or if you give estimate late after the 3rd month, you are not going to get the benefit, and your MACE is going to really increase. And by delaying the therapy, they also showed through a regressive analysis that almost 480 events could have been prevented or would have happened if you do not give early estimate. And as in India, we're very particular that LDL is good, but for us, non-HDL is a better target because it also takes into account the non-LDL particles, especially the low dense and the triglycerides. And here again in the Sweetheart study showed that not only LDL reduction, but reaching the non-HDL reduction is very, very important to reduce the events. Now, the other study was the racing study. Almost 4,000 odd patients were randomized to high intensity versus high intensity with estimate, and they were planning to reach the LDL of less than 70. And clearly, it showed that the people who were on estimate with estimate can get a superior efficacy with better tolerability and low side effect profile. Now, all this started with the Improve IT study, and this was a study that we were also part of in Hyderabad many years ago. And it's a large global randomized study of 18,000 patients. At that time, simvastatin was a drug we were all using. We did not have access to rosuvastatin at that time. And the groups were simvastatin with estimate versus simvastatin alone. And most of the patients were started on estimate within the first week. And we found that people who were on the combination, the MACE was reduced by almost 7 to 10%, and absolute risk was reduced by almost 5.5%, with a significant decrease in the ischemic stroke. And that was the first study, the foundation study about 10 years ago, which clearly showed that it is important to reach LDL, and it is also safe to reach LDL levels less than 60. And it also showed that while statin is the foundation, but adding a non-statin can also give you benefit. And as I said before, the Improve IT used simvastatin at that time, which was not a very powerful statin, with estimate, and clearly showed a 6% decrease in all MACE and a 9% decrease in specific non-fatal MI and urgent revascularization over 30 days, and really showed that when you add estimate to statin, you're going to get better outcomes, you can reach the goal, and you can do that with very minimal side effects. Now, whenever you look at LDL reduction, the ideal window is to start the statin and check after 4 weeks. So that's the general kinetics of LDL. It takes about a month to really settle down with medication. And most of the patients would reach whatever they had to reach by the end of the first month. And you can also do an interim check at 14 days. So if you want to see whether this patient is responding or not, I think the first month LDL is a good time to see them. And if they don't, then we need to add the third drug. So upfront dual therapy, high dose statin with estimate, repeat the LDL at the 4th week. That's going to be your best possible LDL reduction. And then think of the third drug if you're not meeting either the 70 American College, the 55 European Society, or the less than 50, which is the LAI guidelines. And the big advantage is that most of your patients are going to reach the goal. The events are also coming down, and what is important is the SAMs also start coming down. STAMS is nothing but the statin associated muscle symptoms, which is a real big headache in the long term for patients on high dose statins. And if you can get to goal, you can really cut down on the statin and decrease the SAMs by almost 5%. So what is very clear is that the way to go is dual therapy. The way to go is a lipid lowering strategy, less than 70, less than 55, less than 50. Combination therapy really upfront at the time of initiation is important. Doing a lipid at the time of initiation is important. This twin strategy is very safe. The symptoms, the side effects are low, 12 to 19%, and the worst possible thing, that also mild symptoms. And there is no neurocognitive risk even if you go down to less than 30. Um, and adding the second drug is much better than doubling the first drug. You get a 25% reduction if you add, you get only 6% reduction if you double the dose. So based on this, the fixed dose combinations then came when globally everybody realized that you got to have the estimate with the statin because of less side effects, better reaching goal, better MACE. So then the single pill combination came into vogue, and they found that single pill combination is better than giving the drugs separately because you get better compliance, better chance of adherence, and therefore less events. Now, once you've got both the drugs on board, then it's time to look at the third drug, and we've got the third oral drug, which is a citrate lyase inhibitor, which is bempedoic, and we've got now a fair amount of experience that adding bempedoic gives you another 17% reduction. And also, we also know the drug is safe except for patients who have hyperuricemia, who have clinical gout. We need to be a watch on the uric acid. And we also have outcome data. The clear outcome trial clearly showed there's a 13% reduction in patients who could not take statin and were only on bempedoic acid. So the triple combination, I would say, gives you about a 65% reduction, and it is safe and can be added on to the existing single pill combination of statin plus estimate. If you don't reach the goal, certainly then it's time to look at a PCSK9 inhibitor. The EvoPax trial clearly shows that you can achieve the goal, the LI goal or the European goal of less than 55 milligrams in more than 95% within the first 2 months. In-hospital initiation is safe, and we have intravascular data which I already shared with you that you get not only an LDL reduction, you get a plaque stabilization, your fibrous cap gets thick, and the lipid core actually goes down. So at the end of 4 weeks on triple drug therapy, if you're not meeting your goals, European, American, or Indian, this is the time the guidelines recommend initiating PCSK9, while though expensive, has a very, very good cost benefit ratio. The advantage of PCSK9 inhibitor is that initiated early is very fast to act, gets into the bloodstream, and you get all those benefits in the first 8 weeks itself. 50% in the first 4 weeks, and then by the 8 weeks. However, the danger is that it has to be repeated every 2 weeks. The effects are short-lived, and repeated exposure to the drug is important, and that leads to a significant cost uh, problem by the end of the 1 year. So moving on, we have inclisiran, which is a small interfering RNA, and here you're not decreasing the circulating PCSK9 receptors, but here you are actually preventing the PCSK9 inhibitor production at the DNA RNA level in the cell, and therefore the LDL reduction is sustained over a year, over 6 months, and you have to give the drug only twice a year. And the Victorian Inception trial clearly showed that if you start the drug within 6 weeks of the ACS discharge, you're going to get another 45% reduction in LDL, and you get the highest amount of LDL reduction. And therefore, after the initial use of triple drug oral and also the evolocumab, then it's time in the chronic phase to start inclisiran, which will give you a long window period of LDL reduction, having to give the injection twice a week. The big problem here is that it takes time. It takes time for the drug to act because it works at the DNA RNA interface level, and therefore it's not a good drug to be given immediately after an ACS, rather to wait for 6 weeks, let all the acute drugs act, the oral and the evolocumab, and then you give it for long-term benefit. Over and above LDL reduction, we know that Indians have high hyperglycemia. All across pan-India, hypertriglyceridemia is something which rarely comes across. So therefore, LDL reduction alone is not good enough. the reduced IT trial showed that icosapentaenoic acid 4 grams a day clearly showed that because of its good robust triglyceride reduction, which is actually uh, the precipitator of ACS, there's a 37% reduction with an absolute reduction of about 9%, and works even with a low baseline LDL because of its plaque stabilization and anti-inflammatory properties. And therefore now, as per the guidelines, it is routine practice for us, for anybody who crosses the triglyceride 150, we start using icosapentaenoic acid at a dose of 1 gram twice daily. And this is a great dose because the side effect profile is very low. You get a very, very robust triglyceride reduction of about 40%. So this is the way we would go. Patient comes to the ER, LDL has to be done, non-fasting has to be done. It's mandatory to use rosuvastatin 40 or atroba 80. Be my guest, both are equal, but we would rather use rosuvastatin 40 because it's just a smaller dose and therefore the side effects are very less. Patient has a multivessel disease, very, very difficult coronaries, and this patient, remember, now has rosuvastatin 40 with estimab upfront 10 milligram. You don't want to be waiting. It's a triple vessel disease, maybe underwent a PCI or a CABG. We want to start um, PCSK9 inhibitors very early, although the cost is there because these patients are complex patients, they've had complex interventions, and you want to start them upfront and get to goal very, very quickly. For the rest of the people with single vessel disease or non-critical disease, you continue them for 4 weeks with statin and estimab. Look at the LDL. If the LDL is more than 55, you need to use a PCSK9. If the LDL is around 55 or 60, then you can think of using bempedoic acid. If the TG is more than 150, certainly you want to start icosapentaethyl. And if the LDL continues to be above 55 and he has completed about 6 to 8 weeks post-MI, then inclisiran is a good drug to start in the more chronic phase. Always remember that when you check the LDL target, also look at the HDL, also look at the non-HDL cholesterol, look at the triglycerides, lipoprotein A, we don't have a specific drug for it, and look at the HSCR. So if at this point we have a high triglycerides, icosapentaethyl, if the LPA little a is more than 50 and you have not yet reached LDL goal, it's time to look for a PCSK9 inhibitor. So this is the general workflow that we would use in patients with ACS. Now, secondary markers like ApoB and non-HDL are very important in India because the ApoB reflects the total number of atherogenic particles and it's much more superior to LDL. Non-HDL again is more important for India because we have a lot of the non-LDL particles also, especially the triglyceride. So the non-HDL cholesterol really captures all those particles. And the Sweetheart study again clearly showed that if you're able to reach the non-HDL target apart from the LDL within the first 8 weeks, you get a survival benefit. We don't have a drug for LP at this point of time, but we generally use PCSK9 as a drug that will hopefully at least decrease the LPA. This is more or less genetic, it's inherited, and it's very useful to look at the residual risk for those people who already have come down to goal, and then you want to see whether the LPA still is high. We would like everybody to have at least one LPA in their lifetime. And the only drug we have is PCSK9 at this point of time, but pelicarsen, which is a specific LPA inhibitor, is going to come in next year. Now we have another group of very high risk patients who, despite you putting in all the drugs, get recurrent events, target revascularization, despite the very early statin estimate combination. So if the cholesterol is more than 160, you must start bempedoic very early. Check at the 4th week, which is the first month. And if you do not reach the goal, you're not at least 50% reduction, then you need to add the PCSK9 or the inclisiran depending on your patient and the physician benefit. Diabetic patients are at very, very high risk. And in the IMPROVE IT trial, which was the foundation study with Estivib, they found that the diabetics had a 5% absolute risk ratio higher than the rest of the population. People with CKD, again, are at much higher risk than the normal CAD population. And CKD patients are also very, very high risk, so they need to be very, very careful. These are patients you cannot use high dose statins because of the renal disease, so they again really work well if you can start estimab also. Prove It to Me 22 clearly showed that high dose statin is much better than moderate dose. The comparable efficacy of rosuvastatin and atorvastatin is there, but as I said before, it's better to use a smaller dose of rosuvastatin 40. The side effect profile is also very linearly directed with the dose. The PL-ACS registry again showed a mild benefit of rosuvastatin, about 11%, 21% reduction over atorvastatin. There is a slight increase in new onset diabetes with rosuvastatin, but as far as I am concerned, in the early phase of ACS, we have now generally made the transition from high dose atorvastatin to high dose rosuvastatin. High intensity dose, therefore, is the way to go. Dual therapy is the way to go. And more important, single pill, having both is the way to go, because compliance is a very, very important thing, because the drug has to be continued for quite some time. Having an LDL goal, doing an LDL right at the time of admission is very, very important to make sure the event rates come down. If you're going to wait, if you're going to do stepwise intensification over 4 to 8 weeks, you're going to miss the bus, because most of the events would have happened in the first 4 weeks. And as you saw in the chart, that the regression chart, that if you start estimab late, you will certainly be a little better off than people with no estimab, but the event rates are going to be much higher than people you start estimab upfront. So upfront estimab, single pill, combination pill, I think is the way to go. And having a number needed to treat of only 21 at 3 years is one of the most powerful risk reduction metrics in cardiology. And we have clearly showed you that every millimole reduction in LDL cholesterol gives you 22% reduction in major events. So not only the reduction, but the faster you get it down is what is going to count. Otherwise, you're going to miss the bus. So putting all the evidence together, starting both the drugs upfront together, single pill, better than stepwise escalation, better to reach the 55 milligram goal, which is the current recommendation, better to reach this goal quickly to make sure the vulnerable period is avoided, better to avoid delays in slowly uptitrating either to estimab or to statin, and having estimab on board leads to statin sparing, and the safety is as good as having only statin. Now, beyond the LDL, adding LDL causes improvement in HDL, reduction in TG, HSCRP or inflammation comes down, and the non-HDL cholesterol also comes down with all the MACE reduction that is available. So therefore, you will see that if you're able to add the estimab, you can proceed with moderate intensity statin. It is as effective, and more important, no major adverse effects compared to just having high intensity statin alone. So you get all the benefits of LDL reduction, reaching goal, total cholesterol reduction, you're getting triglyceride reduction, minimal adverse reactions, and minimal drug intolerance. So moderate intensity dose with estimab actually better than high intensity statin. So the plan, high intensity statin, start alongside with estimab, add bempedoic at the end of 4 weeks, still not reaching goal by 8 weeks, PCSK9 inhibitor, and make sure that all your drugs count and the events come down. Later, we can move to inclisiran after the 8th week because, or the 3rd month, because then the chronic therapy will be more useful in these patients. Very high risk patients are best suited for a simultaneous or a near simultaneous initiation of statin, STY, bempedoic, triple visit disease, severe disease, very high LDLs. Patient come for the second, third time, recurrent admission, patients with familial disease. We would like to start telescope all the three drugs right at the outset, and maybe after a week or two initiate PCSK9 as well, or maybe even in the hospital. So clearly we've seen that in the acute coronary syndrome, you have to control all the risk factors together: blood pressure, glycemia, thyroid, LDL, all have to come down very, very early, preferably before discharge. Single therapy, single dose, preferably rosuvastatin high dose with estimate as a single pill combination, and you're going to get all the benefits of lipid lowering, the MACE benefit, the mortality benefit, the CV benefit, and you're going to get away from some of the combinations like the muscle issues and the renal issues. So the take-home message today, ladies and gentlemen, is that coronary artery disease, or rather ASCVD, is a big problem. It's a global nightmare. Most of the deaths are going to be because of ASCVD. 35% of the deaths are going to be because of ASCVD. In the ASCVD population, we have realized that modifying risk factors are very important. Among all the risk factors, LDL reduction is really crucial. 8 times, the multivariate analysis shows it's 8 times more important than all the other risk factors. Getting LDL goal is very important. And among the ACVD, ACS is the highest risk, where the mortality at the end of the first week post admission, post discharge, and the first month post discharge is at the highest. And this is the vulnerable period, and this has to be tackled with high dose statin. Important to do a non fasting LDL. Important to start high dose statin with estimate from the word go, not add estimate later. In the very highest risk, you can start all three drugs, and then within the first week, check the LDL. If it's still high, then PCSK9 inhibitor. Most patients with monotherapy would fail the goal. Almost 80% would do that. The LI guidelines are very aggressive, less than 50. In order to reach them, you can't do that with high dose statin. You've got to do it with double or triple drug therapy or quadruple therapy. So our motto and our mission is strike early and strike strong, in order to make our patients live longer, decrease their mortality, and have better quality of life. Thank you very much for your kind listening.
Thank you so much, Dr. Christopher, for that wonderful presentation and addressing a critical gap in post-ACS management with regard to the early use of combination therapy, statin plus ezetimibe. And it was really wonderful to know that you are part of the foundational IMPROVE-IT trial, which recommended the early use of combination therapy in such patients. I guess Dr. Rajesh.
Yes. Hello. Hello.
Hello. Now we will move on to our second talk by Dr. Rajesh Wagh. Sir, will you be able to share the screen, or should I be sharing my screen?
Please share the slides from your side.
Okay, sir.
Yeah.
So our second talk is by Dr. Rajesh Wagh. Dr. Wagh is a consultant cardiologist and associate professor at Bharati Vidyapeeth Medical College, Pune. He's trained at premier institutes like Grant Medical College and BJ Medical College, Pune. His experience in clinical and interventional cardiology with expertise in diagnostic procedures like ECG, 2D echo, TMT, Holter, and ABPM. He runs Wagh Heart Care Clinic with comprehensive, non-invasive cardiac facilities and patient-centered care. He's associated as a panel consultant with leading hospitals including Pune, Ruby, Sahyadri, and Global Hospitals. Dr. Wagh has strong academic background with years of teaching and residency training and clinical cardiology practice. And Dr. Wagh will be talking about women and lipids, addressing the gender-specific risk. So it's over to you, Dr. Wag.
Thank you for this kind explanation. So, without wasting our time, let's start with women and lipids addressing gender. Next slide. So, CVD is a leading cause of global mortality in women, accounting 1 in every 5 female deaths. Despite this high prevalence, female dyslipidemia is historically under-recognized. This is because Indian women are especially prone to low HDL and high triglyceride pattern, which is influenced by early menopause and carbohydrate-rich diet. So, the biological milestones, which are very typical of females, are menarche, pregnancy, and menopause, include dynamic shifts in lipidomics that are often excluded from standard risk calculators. Next slide, please. Yes, so these are some of the typical differences which are there in the lifestyle, in the lifespan of a female. That is uh, premature menarche, polycystic ovarian syndrome, SLE, sometimes rheumatoid arthritis, adverse pregnancy outcomes, hypertensive disorder of pregnancy, gestational diabetes, preterm delivery, small for gestational age, placental disruption, pregnancy loss, early and premature ovarian failure, premature menopause. So, sex specific risk factors, which include women futures risk of CVD, can prevent overall span of lifetime from young adult to childbearing age. So, apart from common risk factors which are also there in females like diabetes, hypertension, smoking, hyperlipidemia, and family history of CVD, these risk factors are also there which are very important. Next slide, please. Yes, so the Yentil syndrome. What is this Yentil syndrome? It is the syndrome where females under 50 years of age are considered to be having less chest pain of mostly atypical pattern. So that's why they are under treated. So that is, even if they have typical chest pain symptoms, they are considered as psychological and anxiety driven. So women under 50 years of age are actually twice as likely to die for heart attack caused by ISD. Next slide. So epidemiology in female. So public awareness of cardiovascular risk remains alarmingly low in female. Study reveals that 70% of Indian adults have at least one lipid abnormality, and they have fewer than one-third of eligible women are prescribed statins. Again, women tend to develop CVD 7 to 10 years later than men, but face a steep rise in mortality after age 70. Unlike men, whose triglyceride decline after midline, women tend to often progress with increasing triglyceride through advanced age. Next slide. So, menarche to midlife, early life programming of risk factor. Early menarche is linked to increased triglyceride, increased LDL, and increased triglyceride. Conversely, late menarche is associated with more favorable lipid profile, including increased HDL level. Every 1 year delay in menarche is associated with 0.38 milligram per day increase in HDL. So, early menarche is bad because it leads to bad lipid profile. Again, combined OC pills can modify lipids, potentially increasing triglyceride and HDL while lowering LDL level. Next slide. Again, so this is the typical lifespan of a female where some differences are there compared to male pattern like menarche, reproductive endocrine disorders, pregnancy complication, menopause, medical risk factor which impact women like diabetes, psychological stress, caring responsibilities. All these lead to increased risk factor in female. Next slide. Yes, so the estrogen shield, this is very important, which protects the premenopausal, has a lipid advantage. That is, estrogen provides female advantage by promoting less atherogenic lipid profile during reproductive years. Estrogen regulates fat distribution, favoring subcutaneous deposition or dangerous visceral accumulation. And these are all factors which are useful in lowering LDL cholesterol level and increasing HDL expression with reverse cholesterol transport to the liver, which is done by estrogen. Next slide. But hepatic modulation, estrogen role in lipoprotein flux. So again, it is same. Estrogen significantly influences the production and secretion of LDL, VLDL, it expresses more estrogen-related receptors, which leads to upregulation of apoprotein B. Again, it leads to interplay maintain higher HDL cholesterol level, which leads to reverse cholesterol transport. It increases apoprotein 1 level, which increases HDL level. Next slide. But the postmenopausal woman, this estrogen benefit is lost, and this leads to rapid atherogenic shift and rapid progression of atherosclerosis with sudden postmenopausal woman gets sudden increase in LDL cholesterol, decrease in HDL cholesterol, and there is a rapid progression of atherosclerosis in postmenopausal woman. Next slide. So autonomic dimorphism, fat distribution beyond BMI. Beyond BMI, females tend to have more, men generally have more visceral fat, while women have higher subcutaneous stores. But this visceral adipose tissue in post-menopausal woman can be nearly double that of premenopausal woman. So this accumulation of abdominal fat is associated with increased insulin resistance. And once insulin resistance is there, it leads to triglyceride level, diabetes, increased BMI, and increased risk factor. Next slide. So the Indian phenotype, visceral adiposity and metabolic risk factor. Everybody knows that even though Indian patients are thin, but they are metabolically obese. So this also applies to Indian women, which may appear thin, but they are metabolically obese because they have more of visceral fat, and that leads to more insulin resistance, and that leads to more risk factor for diabetes, more risk factor for metabolic syndrome, and more atherosclerotic risk factor. Next slide. So the red oculomics, the retina, sorry, the retina as a microvascular metabolic window. So the retinal microvasculature offers a unique non-invasive view to view systemic and visceral health of endothelial dysfunction. This can lead to coronary microcirculation problems, make the eye a powerful systemic marker. Retina is the only area where you can directly see the arterioles of all over the body, and we can track what is happening in all or around the body arterioles. Next slide. So pregnancy, again, definitely pregnancy is a stress which is there in the pregnancy. So that leads to metabolic vulnerabilities, cardiovascular problems. Again, 30 to 40% of pregnant women exhibit at least one risk factor, which affects long-term risk factor. Again, adverse pregnancy outcome can have effect on heart disease, inflammation, and stress. Early detection and intervention during the postpartum period are vital for mitigating future cardiovascular risk. So next slide, please. So preeclampsia, again, preeclampsia and hypertension, vascular lesion. Most of the women with gestational hypertension have 2 to 3 times increased risk of hypertension within 5 years of birth of the baby. It is associated with long-term increased risk of IHD and stroke, long-term risk of dyslipidemia, increased risk of borderline endothelial dysfunction and atherosclerosis. So postpartum follow-up for 6 months to 12 months should be done on all affected women with preeclampsia and hypertension, vascular lesion. Next slide. So gestational diabetes. Again, gestational diabetes, females have 43% higher risk of developing cardiovascular disease. They have often higher risk of development of type 2 diabetes after pregnancy. They have bad lipid profile and metabolic syndrome. And that's why 12-week post-pregnancy, 12 weeks follow-up of postpartum woman should be done for hyperlipidemia, and average and annual glucose monitoring should be done of a female who develops gestational diabetes. Next slide. So again, preterm birth and placental aberration. Again, these are all markers of problems that any placental abnormality, small for gestational age, very large for gestational age baby, they are associated with increased risk of cardiovascular disease and atherosclerotic risk. Next slide. So the Indian metabolic and hormonal inequality. Again, PCOS, everybody knows that polycystic ovarian syndrome is a main marker of actually obesity and metabolic syndrome, which is indirectly associated with increased risk of cardiovascular disease, increased risk of triglyceride, decreased cholesterol level, HDL, increased HDL cholesterol, and all it is associated with increased atherogenosis. Next slide, please. So again, lipid abnormalities, everybody knows that PCOS is again a marker of metabolic syndrome and associated with increased inflammatory cytokines, and all these adversities leads to increased free fatty acids, decreased apoprotein A, increased oxidative stress risk factor. Next slide, please. Yes, the thyroid lipid nexus, sex dimorphic intersection. Again, hyperthyroidism, hypothyroidism, all are associated with lipid abnormalities, which is more common in Indian female, and they are associated with increased risk of cardiovascular disease. Next slide, please. So this is typical feature of thyroid lipid axis. So if patient has subclinical hypothyroidism, it is associated with increased LDL, decreased HDL, and all this is associated with increased atherogenic risk factor. Next slide. Again, uric acid. Everybody knows that uric acid is a marker of renal disease. Uric acid is a marker of inflammation, and uric acid is a marker of obesity. So all these are associated with increased risk factor. So uric acid is primarily produced by liver. Hyperuricemia is associated with dyslipidemia and cardiovascular disease, associated with metabolic syndrome, endothelial dysfunction, and inflammatory marker. Next slide. So again, uric acid is associated with hypertension, dyslipidemia, obesity. Bad food habits are also associated with hyperuricemia, low exercise, kidney disease, medications. All these leads to cardiovascular disease. Next slide, please. So gender dysmorphic links. Again, serum uric acid and atherogenic risk factors. LDL is positively correlated with serum uric acid level. Triglyceride, HDL cholesterol shows an inverse correlation with serum uric acid, and everything is associated with negative cardiac remodeling, especially in female CKD patient. Next slide, please. So statin chasm, that is persistent disparities in therapy. Again, women are significantly less likely than men to be treated with statin, even though they have clear indications. Women had 40% lower odds of receiving any statin therapy, less likely to get up titrated or receiving high intensity statins. So neglected, they are typically neglected. That's why there is substantial gap between treatment, preventable risk, and vascular events and mortality. Next slide. So LDL goal attainment, the skewed success metric. Again, women are significantly less likely. Women are significantly less likely to achieve targets of LDL. 30 to 40% reach this goal compared to 40% only. Higher mean LDL cholesterol is there. So secondary prevention, women are 22% less likely to reach LDL cholesterol goals than their male counterparts. Next slide, please. So statin safety, addressing intolerance and beliefs. So women report statin associated side effects, particularly myopathy, more frequent than men. And the muscle symptoms are primary reason for statin discontinuation or statin stopping. Women have lower belief in safety and efficacy of statin. Hypothyroidism, more commonly in women, can further heighten susceptibility of statin-induced myopathy. Shared decision making and intolerance are essential to improve adherence. Consider hydrophilic statin, rosuvastatin, parvastatin to potentially improve tolerability in women. Next slide, please. So statin evidence in women, pharmacokinetic divergence. Again, this is very important. Differ significantly by sex, with women exhibiting higher plasma exposure to lipophilic statins. And that's why hydrophilic statins such as rosuvastatin, parvastatin are often preferred in women with muscle symptoms. So many trials, Jupiter, HPS, have confirmed that cardiovascular protection is equivalent to men with statins. Low dose initiation and alternate dose therapy is very important. Sometimes it can be done. Next slide, please. So clinical trial inequality, the gender representation gap. Again, women remain severely underrepresented in cardiovascular clinical trial. Historical drug therapy for women were determined by extrapolating male data. That's why pregnant women and those with child potential are often excluded because they are not included in studies. And trials with novel agent like inclisiran still maintains this male dominant pattern. So most of the patients, female, are neglected in studies, and we are interpreting data on male study. Next slide, please. So reproductive potential, evolving statin safety guidance. Again, statins were long considered strictly contraindicated during pregnancy and breastfeeding, but the US FDA required a removal of strongest contraindication label from statin labels. So guidelines state that continuation may be considered in very high risk pregnant females. Women planning for are generally advised to discontinue therapy for 1 hour months before conception. Reliable contraception concealing remains mandatory for women of childbearing potential. Next slide, please. So again, aggressive goals in Indian practice should be also followed in the female. Next slide, please. Yes, global perspectives comparing international guidelines. Again, they show that woman specific consideration should be there with premenopausal, preeclampsia, postmenopausal, all statins, all guidelines should be considered in women. Next slide, please. Next slide, please. Yes, rosuvastatin and female paradigm, clinical evidence and pharmacokinetics. It's always proven that in many Jupiter and most trial that rosuvastatin can be considered in pregnant in females with very less risk of myopathy. Next slide, please. So, women face higher cardiac risk at low plaque burden. This is very important that even though they have small plaque, but they can suddenly rupture and that can lead to myocardial infarction even with low plaque burden. Next slide, please. So earlier risk threshold in women should be considered and treatment should be started because they have low plaque burden in women than in men. Next slide, please. Again, Saturn trial, they have proved that sex-related differences in atherogenesis regression is there in females. Next slide, please. Again, rosuvastatin is superior in atheroma reduction in women compared to atorvastatin. Next slide, please. Managing severe familial hypertriglyceridemia, navigating reproductive challenge, and females are usually diagnosed late. So contraception choices should be with low estrogen formulation to maintain adverse effect. Next slide, please. So conclusion, cardiovascular disease is primary cause of female mortality and it are neglected in the female. So critical window of cardiovascular risk classification should be there. Rosuvastatin is a robust protective statin which can be given in female. Aggressive treatment should be given with good goal achievement. Improving adherence among Indian women with culturally tailored strategies should be well addressed with, and long-term cardiovascular equality should be taken care of. Thank you. So conclusion, CVD is preventable and females should not be ignored. Next slide, please. Same dyslipidemia in women. Next slide, please. Okay, thank you.
Thank you so much, Dr. Wagh, for that wonderful presentation, wonderful and insightful presentation, and highlighting the under-recognized risk factors in women and also in terms of management optimization. Now we will take few questions. There are a few questions. Now, first question to Dr. Christopher. First of all, thank you so much for that wonderful talk and highlighting the significance of early use of combination therapy post ACS. A few questions to you. First of all, despite of these guideline endorsements, upfront combination therapy it remains underused. So what do you think that what are the key barriers in a country like India, and what are the real world practice barriers which especially in the high risk post ACS patients?
Yeah, there is a lot of physician inertia, I would say, right, to start with. And we have not been doing LDLs at the time of entry, thinking that we want to do it the next day, we want fasting. And next day just never came, because the intervention was done in the night. Patient is shifted back, and the cardiologist is hardly worried. He's more worried about the ECG, the groin hematoma. He's worried about the hemoglobin post-op, creatinine because they're given contrast. So the LDL quietly slips away. He's very happy to see his 40 milligram rosuvastatin the nurse is given. He's got the ticagrelor and the aspirin. So there are a lot of things occupying his mind on day one. So the LDL gets conveniently, sort of slipped under the rug. And many times, even the next day, due to various reasons, the lipid never gets done. Thyroid never gets done, gets missed because the whole focus is on the post-intervention, the CVP, the RP2, which happens. So that's the first step where things go wrong. The second thing is patients obviously have a little bit of pain post MI. They have some groin pain, they have some limb pain. So the cardiologist is a little worried. He's worried because he's given contrast. Patient had little AKI. Patient was dehydrated, had vomiting when they came in. So he's really scared of rhabdomyolysis. That's on top of his mind. So he's really little averse to giving very high dose statin. He's done a very good job on the PCI. He feels his stent approximation has been good. He's used IVUS, so the chance of a recurrence TVR is going to be very, very low. So he says, let me just get away with a little lower dose statin, or just single dose statin should be fine. Don't want to increase the pill therapy. He's already on ticagrelor, aspirin, pantocid, Krimif, and so on and so forth. So a lot of things are occupying you on day 0, day 1, and the lipid just conveniently moves out of sight. And even if it is there, he says, okay, there's 4 weeks to go. Let's see, let's not do too many things. The family is very apprehensive at the time of discharge. They say there are so many medication. Doctor, you put in 80 milligram of Avaturva. We've heard a lot of things in the media about renal issues, rhabdomyolysis. My husband gets a lot of muscle pains every day as it is. So a lot of apprehension when they see those big numbers. So that's the reason why I prefer rostatin 40 than 80, because 40 is a much better number to look at. And availability of estimab at the point of care is sometimes limited. Pharmacies don't stock it. Single pill combination 40 with estimab is there, and I think only 3 companies as of now, if I'm not mistaken. So the pharmacist invariably does not have that combination. He has estimab separate. He has got rosuvastatin. He's got, but single pill 40 with 10. I know only 3 companies that have it, and most pharmacies don't stock it. So there is a problem about clinician inertia. Then there is a problem about patient apprehension, and the last problem is the availability of the drug itself. So when you don't have 40 rosuvastatin with EZ in the pharmacy, it quietly gets slipped away. High dose statin is all the patient gets. He comes back after 1 week in a crowded OPD. The LDL has not been checked. The family didn't check it. They're more worried about the stent is there or not, the stent is occluded or not. He's more interested in checking his ticagrelor, aspirin, and that one statin tablet. The LDL never makes it to the front page. He's more worried about the small hematoma that is formed. Patient is having some atypical chest pain that is worrying him, so he wants to start a little bit of nicorandil. So a lot of things occupying in a busy outpatient. He's mentally happy that the patient came in, didn't have any problem in the first week, and he's glad to get rid of the patient so that he comes back after a month. So estimab, small little molecule, never really sees the front page, and with the patient already on a high dose statin, the clinician feels very nice and smug. So he starts getting an alert at the 4th week when the patient comes in, and now the LDL is 110. He's on a high dose statin, and then the alarm bells start ringing. And he said, oh my God, high dose statin 40, 110, not acceptable. I need to get to goal. And then the estimab comes in. Then there's another, the 4 weeks have gone by, we missed the bus. And estimab then gets added on. And after 4 weeks, when he comes again, LDL is at 70, and then or 75. And now we know the guideline is 50. So then bempedoic acid starts coming in, and that's another 8 weeks which has gone by, and the events start happening now, because simply because we've had 8 weeks of very high LDLs, and ACS starts happening. And when the chest pain starts happening, again, the lipid is the last thing you're looking at. You're looking at Clexane, you're looking at changing ticagrelor to prasugrel, you're looking at admission, you're looking at nicorandil infusion. So a lot of things occupying you in the first 4 weeks when the patient starts having chest pain. So it's just one after the other. In fact, there is a very nice National Geographic program which says seconds to a disaster. Seconds to disaster is an air crash investigation, National Geographic, and they do a dissection about the various steps before the air accident happened, right from the pushback from the apron to the mechanic not fitting the right wing flap, so on and so forth. So this is exactly the same thing. And at the end of 8 weeks, a high LDL, a chest pain syndrome, and you've just missed the bus. So I think it's really, really important, and I'm telling this to all the companies, please stock up on your 40-10 or your 80-10 in the cath lab. Keep it there in the cath lab, stock the cath lab. Don't worry about the pharmacy, don't worry about your medicine not getting billed for. Give it to the technician, to the nurse directly, do programs with the technician nurse. Every patient that walks out of the cath lab should have a tablet of 40 and 10 in his mouth orally. The tablet should get carried into the ICU. The ICU should get carried into the ward. The ward should get carried to the house. The house should come into the OPD. And when the consultant sees a 40 and 10 single pill, he's not going to remove it. He's very happy. And the estimate on board is going to alert him with the first week itself that, hey, let me get the LDL done because he's on a big combination, single combination, big combination. So the estimate there is going to start making him think about it. And he will tell the patient, don't wait for 4 weeks, get it done tomorrow if you've not got it done. And let us say the patient is at 70 now, he immediately initiates the bempedoic acid. And he said, now don't meet me after 4 weeks. I want you to come back within a week. And if the bempedoic has kept the LDL at 60 and not at 50, he says you need to have a shot of evolocumab. At least one dose of 143 milligrams, you get it done. So a lot of things starts happening by the first 10 days. And basically what you're doing is you've not missed the bus, you're on the bus. And if you're on the bus, it means you're going to reach the destination safely. So this is just a little dissection as to how things go.
Right. So, thank you, sir. My next question to Dr. Wag is, there are evidences which suggest that there is a higher impact of Lp(a) in women, and the question is regarding, should we routinely screen all the women for Lp(a), or should we change the management decisions accordingly as well?
Okay. Regarding which delay you said? Regarding?
LPA, lipoprotein A, sir.
Okay. Lipoprotein A level. Yes. So basically, the females which have got a bad obstetric history, like those who have got gestational hypertension, gestational diabetes, or babies which were very large, babies which were very small, with early menarche, with bad family history, these females should be screened for all lipid profile screening. And the problem in Indian scenario is that most of the females, in young females which are below 40 years, who are regularly menstruating, they are considered to be safe with cardiovascular diseases. They are not suspected to be having any cardiovascular disease. So that's why the screening which is usually done for male patient, the female patient screening is not that commonly done in Indian scenario. So that is the problem. And again, in Indian females during pregnancy, if they are detected with diabetes and hypertension, once pregnancy delivery is done, they are not bothered, and they are not doing their regular test, which has to be done every 6 months or 12 months or yearly. So they forget that they had got diabetes and hypertension during pregnancy, and that should be regularly screened for, because the incidence in those females of having diabetes, hypertension, and dyslipidemia is very high. Again, the problems which are very common in females, which are very rare in males, like rheumatoid arthritis, mainly SLE, systemic lupus erythematosus, then this connective tissue diseases, and uric acid problem. Again, some arteritis problem, Takayasu arteritis, inflammatory disorders, and what I want to say, hypothyroidism. They are also associated with lipid abnormalities. So we should also focus in those females lipid abnormalities. We just forget that, we just treat that condition. Uric acid, okay, treat uric acid. SLE, treat SLE. Hypothyroidism, treat hypothyroidism. For those patients should be screened for dyslipidemia, and that aspect of the disease should also be treated. That is totally neglected in Indian scenario, which I want to stress that these things should be addressed in female patients.
Great, sir. Thank you so much, sir.
Yeah.
My next question to Dr. Christopher, one more question for you. that you mentioned the benefits of a combination therapy with regard to plaque stabilization. So, what is your experience with regard to this upfront use of combination therapy and plaque stabilization? As such?
Yeah, I would say that, we now have moved away from stenosis to plaque. As I said, we made this great jump, a great transformation. And to me, plaque is the way forward. Non-invasively, we're doing a lot of CT angios and we're picking up plaque, treating them. We are doing intracorneal imaging with IVUS, OCT, and NIRS, small numbers, obviously. And we now know that plaque is the center stage for all strategies and to prevent MACE and not the stenosis as such. So saying that, we are now beginning to see both in the non-invasive CT as well as the invasive that if you put aggressive lipid lowering therapy up front, combination therapy, double, triple, or you use evolocumab early or inclisiran later, not only the MACE events are coming down, but we are morphologically seeing these plaques shrink. We're seeing the plaque shrink. We're seeing the lipid component coming down and the calcified component increasing. And this is now visible to us on longitudinal follow-up. And more calcium means more stability. It may mean a little more stenosis, but the stability is guaranteed and the MACE comes down. So now we have the instruments, we have the techniques, we have the ability to see the plaque up front. It's not something which is hypothetical or imaginary. And I have a good number of patients that have done CT, shown lipid lowering plaques. Patient came after 6 months, repeated the CT. It's not in the guideline, but individual patients are very particular about their risk and they see the CT and I find the plaques almost disappearing when they're on double or triple therapy. So yes, we now have the clear evidence that these drugs work and well, we don't have our own smart data from our own institution, but Indian data is now available and clearly showing that double therapy, combination therapy upfront really works.
So, thank you so much for those valuable insights, Dr. Christopher. Um, uh, there are many questions lined up, but as we have already exceeded the time, we'll not be able to take up those questions. Before we officially close, on behalf of Nexa Division of Intas Pharmaceuticals, I extend my heartfelt gratitude to all of you for being part of this enriching session of Lipid Lecture Series. And special word of thanks to our both the esteemed speakers, Dr. Christopher and Dr. Wagh, for your insightful presentations and thought-provoking perspectives on lipid management and cardiovascular risk management. To all our attendees, thank you once again, and thank you for your time and engagement. And we hope that this platform, Lipid Lectures from Lipitas, it continues to support your clinical practice with meaningful science and expert collaborations. Um, Wishing you all a very pleasant evening and a good night. Thank you so much.
Thank you. Thank you. And
Thank you very much.
thank
Thank
you
you,
to everyone.
Intas. Thank you, Dr.
Thank
Sandesh.
you.
Thank you so much, sir.